Hello everybody, my name is Bronwyn Delaney, and on behalf of Metaphorical Therapy I'd like to welcome you to our discussion this afternoon. I'm joined today by Mark Whittington, Dr Mark Whittington, who's a consultant psychiatrist. How are you going, Mark?
Well, thank you.
Also joining us is John Brownhill, who is now John, help me get this correct. John, you're practicing out of Southport in Queensland. You're a psychologist with a special interest in anxiety, depression and PTSD?
That's right, yes. I'm a clinical psychologist.
Clinical psychologist. All right, you have to forgive my loose descriptors. We're going to have bios for both Mark and John's contacts in below the content of today's discussion, so you can visit and learn more about them as practitioners and their areas of interest. So let's kick off the discussion today just very generally to learn a little bit more about what the so-called mental health crisis in Australia. So John, I'll open with you. Have you seen much change in your practice over the course of the last 2 years post-COVID?
Yes, I've seen a lot. Just anecdotally, most of our waiting lists have just grown exponentially. So, just one source of data, just the waiting list to see a psychologist. It's really blown out with COVID. We're also seeing a lot more people accessing services for the first time that probably usually wouldn't, like your middle-aged guys and things like that. And I think that sort of just means that the message is getting out there and that it's becoming more, services are being more available, but they're also more acceptable these days. But yeah, there's been with COVID a lot of extra demand for my services, that's for sure.
Now, can I just probe that a little bit further with you? What's the nature or the most common presentations of problem that you're seeing?
It would have to be some type of an anxiety disorder, I'd say, closely followed by a mood disorder, and alcohol. So some alcohol-related issue would be number 3, and often a combination of all 3.
Sure. So, Mark, obviously over the course of COVID, we've all become a little bit more accustomed to the digital or electronic delivery of mental health services. Over the course of your practice in this period of time that we're referring to post-COVID, what have you seen happening in your practice? Obviously, psychologists and psychiatrists have very different areas of interest and different approaches to treatment. What have you observed over the same period?
Well, I've got a chronic population of quite seriously unwell people, so many of them have already sort of fallen over before COVID. But I do note, as John said, that there is a lot more people who are presenting for the first time. And I'll see people who suffer from more severe illness because they might need medication. But there's a huge overlap between the psychiatrists practicing psychological techniques and the psychologist. The psychologist may be the recognised expert, and our domain will be primarily medication. But you can't just sit there prescribing. That takes 5 minutes, whereas you've got to do something with the rest of your time, and that's where we have the opportunity to actually teach people psychological techniques, coping strategies, etc.
So interestingly, in that overlap, in terms of complementary supports and other therapies that people can undertake, John, have you seen a change in, I suppose, the resourcefulness? There are a lot of sort of online mental health service delivery protocols that are available at the moment, and we think about things like the Black Dog Institute, who've deployed a lot of resources in delivering services online. How effective and how frequently are those interventions used amongst your patient population, and what have your observations been about their helpfulness?
Well, just regarding helpfulness, some of the outcome studies for phobias and panic disorder and agoraphobia seem to be comparable to face-to-face. Yeah, but a lot of, like, it's a new thing. Like all things in IT are pretty new. And you see all the major inventions, I'd say, of the last 20 years are an IT type thing. basically, and it's no surprise that our services are sort of within that world. But yeah, people are becoming a little bit more trusting. I think some cohorts are always going to be more tech open than others. You see a lot of the apps and the IT type interventions are very brief, which I think is catchy, and they seem to be flirting with artificial intelligence. Some of them are starting to use bots and things within them, which is sort of exciting, but probably, you know, very new, and it needs to be sort of more probably thought out and tested out.
Sure. So in uptake of these types of services, obviously one of the benefits I see as a layperson is that there's a subset of people who I think would just never consider stepping foot into a practice, or, you know, especially I'm thinking older males, but that's probably just a personal bias of, you know,
That's
you
probably
see that
correct.
tough guy approach. I'm sure there are plenty of women who are the same, but just people who are reticent to accept help face to face, who may in fact be less reticent to pick up one of these either diagnostic or support therapies digitally. Would you agree?
Yeah, it's anonymous, which is one important aspect, and it can be timely. Like getting to an appointment for an hour every week, often 9 to 5, that can be tough. So yeah, just the way it's delivered can be sort of easier and mean that more people are likely to do it.
Right. What are are any of the programs and therapies that are available in the mainstream at the moment? What are some of the ones that your patient population are actually utilising?
Well, for years we've been directing people to psychoeducational material. I've had $1 every time I've sent someone to a sleep hygiene website. You count it. Yeah, so you know, for years we've been doing some things like that. But many of the manualized interventions, like some interventions are more manualized, such as things for, you know, exposures and behavioral interventions. And they are very sort of good to do in that online sort of format. I think, you know, before the technology's really been explored.
Right. So, Mark, listening to this conversation and understanding how within a psychologist practice these therapies are becoming more utilised and more referred to, in developing, first of all, tell us a little bit about metaphorical therapy, but also if you could just frame your response just around how you've designed it to deliver against this particular patient need that we're talking about.
Well, see, my driving force in terms of, and the reason why I sort of have persevered with metaphorical therapy is because as a clinician, especially as a psychiatrist, you're only just one person seeing one patient at a time and have a limited patient load. There's more psychologists, but still it's a labor-intensive intervention. So what I was motivated about was really trying to actually reduce the principles down to key fundamental lessons that I could then teach people in terms of preventing mental illness. And I'll be interested to John, what there is out there in terms of preventing illness, because we're taught to look after our physical health, you know, wash our hands, clean our teeth, eat vegetables and exercise. But there is nothing really out there that actually are those fundamental lessons. So I thought, well, if I could get it down to the tin tacks in terms of what those principles were they going to be then carry over in terms of prevention? But really, when it comes down to treatment, people have already fallen off the cliff when they're coming to see John and myself. And so therefore, I specifically targeted treatment modules. And we all use metaphors in treatment. They've long been established in terms of psychotherapies and certain types of CBT, cognitive behavioral therapy, such as ACT or acceptance commitment therapy, have therapist-generated metaphors. But the point is, they carry so much weight and meaning, and so therefore I was motivated to try and make something that's simple and easy and digestible and practical. And so that's why I created, say, the storm of anxiety or the winter of depression. And if I just ran through, and John, you wouldn't have heard this, how I would teach someone the symptoms of depression, if I may, Bronwyn.
Sure, please.
Okay, so I say depression is like the long, cold, harsh, personal winter in which it's too cold to go to sleep. Waking up, I feel exhausted. I don't want to go outside, and when I do, I don't understand why couples are dancing in the rain and children are playing in the snow. Walking is like trudging through soft snow with a backpack of guilt, through the fog of confusion, into the valley of darkness where everything is bleak, lifeless and grey, and all I want to do is to go to sleep in the snow. So when you pick that right metaphor, it resonates with the patient. And so what I've done in mind movies, those stories or journeys through the winter of depression or the storm of anxiety, what I'm able to do is shackle treatment or advice to the story, sort of like a mnemonic. So the person has what we call in linguistics and cognitive metaphor theory is embodied experience. And just to make it simple, we've all experienced winter, so we know what it's like. So we use our experience of winter and then apply it to how that marries with, say, depression. So that carries over so much meaning, which is exactly what metaphors mean. They carry over meaning from something known, concrete and clear, like the winter, to something vague, ambiguous or unclear, like depression or anxiety. And so this is where I'm able to absolutely have some traction with my patients, because I can educate them and at the same time assist them in terms of some of those practical psychological strategies.
I
John,
would imagine that.
Yep, where you go, Wanda.
No, I just had a further question on that, because I've heard and listened to some of the material for metaphorical therapy, and one of the things that strikes me is it's very unflinching in its metaphors. It really does describe the very acute lived experience that people can relate to, and it's an incredibly empathic experience to actually listen to what's being said within those metaphors, and there's an implied understanding and acceptance within what you're listening to that it's worth staying on the journey of the narration, because it's headed somewhere that is coming from something familiar, coming to an easing of that problem state. So just asking John the question, when you have somebody who's coming in with an acute situational stressor, they're face-to-face with you for an hour, how helpful can these therapies be in easing someone's anxiety or trauma in the hours when their clinician isn't available?
Yeah, well, that's the first time I've heard Mark describe or give that metaphor for depression, and that was actually quite powerful. Yeah, look, how people understand what's happening to them is often very important. And for many people, a mental illness is a frightening surprise that shocks them and disorientates them. And having some understanding of that what's happening to them may be, less common but normal, can, mean that people actually try.
Just picking up on that point, that's really what happens when we give that story of depression or anxiety. It resonates within, and you felt as a clinical psychologist that actually metaphor fitted. And so I agree totally with what you're saying, is when someone is acknowledged that the way they're feeling is understandable and other people feel the same, they don't feel alone. They feel a sense of support. They feel a sense of commonality. And that's huge. That's huge, because if someone else has been there before and this guy recognizes it, you, me, anyone in the mental health profession, then I'm not alone, and maybe there's a path out of this. And see, one of the things that I really are so enthused about with like the metaphorical mind movies is if a person accepts that they have, their depression is like winter, then we have a symbol and some hope, because at the end of winter, spring must come. So embodied in that is hope, is the possibility of an outcome. And I do have a pack of sunflower seeds and a bright yellow sunflower. And this is what I give to patients with the caption, spring must come. It's not a question, it's a fact, it's a reality. And with spring will come the end of your depression, your depressive episode. So it's really, really powerful. And I think a lot of people misunderstand the whole thing about psychologists and psychiatrists. Psychiatrists are treating people who require medication, but at the end of the day, depression or anxiety is not happening in a vacuum. And the psychologists are really there to try and extract and look at those psychological factors that are contributing to why a person falls over, gets anxious or depressed. So there's a lot of commonality. And what I hope is that the metaphorical therapy can be used as like a plug-in for anyone who's in the mental health arena, whether it's psychologists, doctors, GPs, because we're all time pressured. There's not enough time to see all these patients. And if we have some shorthand way of educating and doing the basics, then that's going to make it's a game changer, I believe.
John, in your practice, what is the demographic of patient that you're seeing that is fastest growing? We hear a lot about mental illness in young people, and anxiety is being created by not feeling a part of things, social isolation, the tyranny of digital media, and the fact that young people are made to feel not up to scratch because of all the influences and all of the heavily branded socioeconomic pressure on them. Where in the continuum of service delivery do you see the greatest opportunity for a therapy like this? Is it youth? Is it adult? Is it across the board? How would you see it?
Yeah, it's a tough one. Probably I'd be thinking slightly youth, that the youth may be more likely to pick this up. It might depend on how it's delivered. But during the years of COVID, we saw a lot of middle-class, middle-aged people presenting for the first time. And I'd say it was just stress. Fear of illness, fear of the unknown, fear of going broke and losing things. But I don't know, it might be, metaphors are often powerful across generation. It might be how it's delivered. It might determine the cohort that's most likely to pick this up.
Question for you, Mark, just with respect to the idea of this being a preventative therapy that people can undertake or a support, how would you see it being applied? Do you think that there's a purpose for it with aged care patients right through to youth, or where on the line do you see it working?
Well, you see, the way I've crystallized those basic keystone principles is that they are universal. So I'll just give you the principle first, the one of the 4 keystone principles, and that's called self-preservation. I say self-preservation must come first, but all of us in mental health education run across the point of resistance. You say look after yourself, but families or parents have this view that it's virtuous to be self-sacrificial, that it's selfish to put my needs first. And it's encapsulated in the caption, I'd die for my kids. But when we present self-preservation through the use of metaphors, it carries different meaning. And I'll just recite our little verse or whatever. The mother puts the oxygen mask on herself before the baby in the plane because she's useless if she dies of hypoxia in front of him. The ambulance, lights and sirens slows down at the intersection because self-preservation is not self-interest. The police, armed and dangerous, will call for backup in a robbery because self-preservation is not self-indulgence. The surf lifesaver will not be able to save you without the rescue tube because self-preservation isn't selfishness. So John would recognize that I'm doing cognitive restructuring in those things. And then we finish off by doing something a bit tricky, and that's cognitive dissonance. As a parent, unless you model self-preservation, unless you practice self-preservation, you will teach self-neglect to be replicated in your children's future relationships and their workplace. So what I've done, surreptitiously, I've created a conflict. On one hand, I die for my kids, but I'm teaching them to neglect themselves. So the person has this aha moment and they think, oh, I must have to practice self-preservation in order to teach self-preservation. I need to look after myself. And the penny drops. And all of a sudden, my patient's behavior changes. They get it. And that is the first principle that is starting to pave the way for prevention of burnout, or parents running themselves into the ground, or anyone in the workplace. And whether it's an older person or a younger person, it's a universal truth. I've got to look after myself. So then, and this is one of the key differentials in terms of the use of metaphors and metaphorical therapy. Metaphorical therapy is interlinked metaphor. Now, in ACT, they have therapist-generated metaphors for a specific purpose, but I have a fundamental series that are universal. And if I just introduce the second principle, and again, it's done in metaphors and pictures or illustrations, because we say metaphorical therapy, therapy at the speed of sight. So it's quickly absorbed and assimilated. So therefore I say, you cannot have a country without a border. Picture a border. You cannot have a property without a perimeter. You cannot have a self without a boundary. Now here the two are linked, self-preservation and boundaries. You cannot practice self-preservation. You cannot practice self-preservation unless you have a boundary that separates you from your neighbour, be that your parents, your partner, or your children. And then I say, well, what is a boundary? Well, of course, it's a metaphor. I have a line in the sand with someone who I love and trust, a picket fence for a good friend, a wooden fence for a more peripheral friend, a barbed wire fence for a work colleague, a brick wall for people I don't know and don't trust or who are addicted. So all of a sudden, this unclear, ambiguous boundary notion is concrete and clear. And this is what the linguistics say: source metaphor, using the fence to carry over meaning to the boundary. So boom, now it's connected. Now the person who now is going to practice self-preservation thinks, okay, I've got to mow my lawn, pick up my rubbish, attend to my property. But how can I attend to my property if I have an ambiguous boundary? I might be mowing someone else's lawn, picking up their rubbish, or they may be dumping their rubbish in my property. So what we see is, in the metaphor, the person is able to think through and marry up their own problems. But what happens with the use of metaphors is you do that at a safe distance. I'm talking about a property and a fence, but we're really talking about the boundary between me and my kids, or my addicted uncle, or my alcoholic mother. But a boundary is not just a single dimensional thing. In metaphorical therapy, it's expanded to be a whole series of events. And when you present it like that to your patient, all of a sudden, again, there's this light, lighting up or whatever, in terms of getting it and understanding. And when they get it and they understand it, they recall it. And this is, I mean, they talk about metaphors and images as being kindred spirits. And so when we use the right metaphor and we present it visually, it has a very, very powerful effect. And one point I'd like to make is that when we use metaphors, say like my depression is like winter, we're looking at and describing from a distance. But in the mind movies, when we use the image, now I'm in winter. And it's what we call an embodied experience. So I know what it's like to go through winter. Now I apply all that learning onto what it's like to have depression. Or I know what a fence is. Here's a line in the sand separating me from a close trusted friend. And here's a brick wall, which is substantial defense because I need protection from this unhealthy person. So it's sort of kind of like, it's sort of like common sense, but it's like John's saying, it's how it's presented really is the point of difference, and one of the key benefits of metaphorical therapy.
Within your answer there, I certainly see the potential for harm prevention. So not only is there identification and the solace of knowing I'm not the only person who's had this experience, but potentially the capacity to prevent and skill build as well, because within that metaphor, there is basically embedded guidance about how to apply boundaries going forward, not just the past trauma that you're seeking coverage from, but also a skill set to take into your future life, which says, how could I treat this person or a particular situation using that metaphor in an applied way going forward.
That's exactly the point, Bronwyn, because how many people get anxious or fall over with depression? They didn't practice self-preservation. How many of them get anxious because they have ambiguous boundaries? How many people get depleted because they're mowing other people's lawn and exhausting themselves because they didn't have a fundamental appreciation of this nebulous concept of boundaries? It's that they're clearly closely related.
So a question for John, listening to this discussion and understanding the application of metaphorical therapy, thinking about the influx of new clients that you had coming into your practice over the period of COVID, had these individuals had access to or better preventative care, do you think their experience would have been the same? Do you think some of these skills forelearned would have affected their outcomes? It's a bit of a back the front question, but I think you understand what I'm trying to ask here.
And it's probably there's a PhD in there for someone, you know, to really properly answer that. You need to remember that the most number of sessions someone does is one. Okay, if you look across all the statistics, the mode is one. And you know, some of the material that we provide to people is pretty dry. It's very informative. You know, we print off, oh, you've got depression. I'll press print and give you some handouts. So I'd be very interested to see what the difference would have been, to be perfectly honest. It'd be worthy of a study. But you know, just on the face value, Mark's metaphors seem to be a little bit more cutting than maybe what we're providing, which is your standard. Just, you know, you give them usually a handout on the disorder or what you're treating, and then one about treatment. So yeah, no, I'd be very interested. I think it probably could cut through a little bit.
Well, that's the thing. Being given a handout sheet is an impersonal experience, and I think one of the things that strikes me about the metaphorical therapy is that it is an internal process of acceptance of the metaphor and what it means to the individual and how they apply it, rather than just a pro forma response.
Well, there's a reason human beings, we deal in metaphors. They have value, and we've always done that, you know, for thousands of years. So yeah.
Well, it's interesting even on that point, John, because it's been demonstrated that children as young as 3 are proficient at the use of metaphors. And for example, that crust is a curb, the broccoli is a tree, that centipede is a comb, that freckle is a cornflake, the man had a barefoot head who was bald. So it's been demonstrated that not only do adults use them, but they're actually the operating system of the subconscious mind. We dream in metaphors. We could not, you wouldn't understand it. You wouldn't appreciate it. I mean, that metaphors are just part of our everyday speech. You could not talk or communicate without metaphors. I feel up, metaphor. I feel down. Things were ahead of me. My problems were behind me. My right-hand man is a metaphor. I shouldered a problem. Someone cried on my shoulders. Someone was head and shoulders above me. You know, there's everything that we speak about is actually metaphorical, and you would be pretty well mute or non-communicative without it. But it's kind of like, if you're going to explain something new, you explain it in terms of what is known. What does crocodile taste like? Well, it's sort of like chicken. You know, it's a to and fro between them. So yes, we've used metaphors, but I don't think people have, and certainly in the profession, this comes out of linguistics and the cognitive metaphor theory that says that it's a constructionist view for you know, we construct our world in terms of through our understanding of metaphors. So really, the use of metaphors resonates deep within us all as individuals. There's probably one exception, that's people who suffer from ASD, autistic spectrum disorders. They have difficulty in deciphering some of the metaphors, a bit more sort of concrete in terms of their thinking. But for everyone else, from kids to adults, male, females, and cross-culturally, metaphors are just part of the way we think.
Just a final question, John, for you. Understanding that patients present with, you know, long-term mood disorders and then situational crises, in applying this kind of a support, do you see a particular weight or a particular point of intervention where it would be more beneficial, or do you think it can be applied across the board?
Look, prevention is always important. You know, some people have recurring issues, so you know, where you intervene is important, but usually, you know, at as early as possible, I think, would be the general answer there.
And Mark, just finally, understanding that life goes on and the world is a changing place, are you looking at introducing any new metaphors, or how are you looking to evolve the therapy as time passes?
Well, it's funny, it's been evolving over 20 years, and what I have built up is a framework of understanding of interlinked metaphors. So when I've come across a new metaphor, I just tap it into an existing structure. So really, within metaphorical therapy, I've got a metaphor, therapist generated, that has been practiced, tried and true with thousands of patients. I'm doing, but I really want to get it out there, and I really want it to change the world almost from really the ground up in terms of teaching kids right in kindergarten. Those change the world almost from really the ground up in terms of teaching kids right in kindergarten, those basic principles of keystone principles of mental health. As far as I'm concerned, this is just the beginning for me in metaphorical therapy and the team here.
Agree. And certainly links to more information about metaphorical therapy will appear below, along with bios of Mark and John. Gentlemen, thank you so much for your time this afternoon. It's been lovely speaking with you, and wish you a happy remainder of the day.
Thank you, Bob.